Good morning, everybody. I would like to thank very much Professor Patrigios for inviting me to speak today about thyroid cancer in children and adolescents and the situation worldwide and in Cyprus. The questions that are going to occupy us for this short presentation is why thyroid cancer is increasing dramatically worldwide and what we can do to prevent it better. My objective is, first of all, to speak a little bit about the epidemiology of thyroid cancer, the increasing temporal trends which have been documented worldwide, whether it's overdiagnosis or true increase of thyroid cancer, the differences of pediatrics, and when I will use the term pediatrics for thyroid cancer, I mean the 0-19-year-olds versus adults, the etiology, important, the actual situation in Cyprus and worldwide, and what to do next. Thyroid cancer is the most common endocrine cancer worldwide. Women are affected more frequently than men, with a ratio 4:1. Today is the fourth most common malignancy in women, or in the 1990s, it was the 14th. So you see the important increase of incidence. It remains the commonest cancer in women less than 25 years old. The rapid global rise of incidence, the annual percentage change is approximately 5 to 7% yearly, and it's mostly the papillary thyroid cancer, of which there are four main histological types, the papillary and follicular, which are the differentiated, and that are iodine avid, and thyroglobulin can be used as tumor marker. Then we have medullary and calcitonin can be used as tumor marker, and medullary anaplastic are non-differentiated types. The increasing incidence rates and temporal trends have been documented by many studies, like the one I'm showing you here. But at the same time, we see that it's mostly the papillary type that was increased. And at the same time, not only the overall incidence increased, not only the papillary, but at the same time, we see that the number of nodules, as you see from this slide, fortunately, the presenter view doesn't work well here. However, not only the number of nodules, but also the stage. So this is more against the theory that it's overdiagnosis, the predominant reason. This has been documented by various studies about the impact of the overdiagnosis. And what is overdiagnosis? Is the increased detection of small thyroid nodules that are papillary lesions. These have been found because there is increased testing with ultrasound, CT scan, MRI. These, if they wouldn't have been discovered, they would have remained otherwise indolent with no lethal evolution. They remain asymptomatic. And without this increased testing, they would remain undetected. And this overdiagnosis, again, has been accepted as a consensus among the researchers. However, the impact of overdiagnosis, we have to look at it. It leads to overtreatment and unnecessary therapies. And overdiagnosis is a major avoidable burden for patients and the health system because, as it is easily understandable, it leads to lifelong sequelae, hypothyroidism, second cancers due to iodine therapy, recurrent laryngeal nerve injuries, hypoparathyroidism, because sometimes during the operation, parathyroids are damaged, and of course the burden of cancer diagnosis on patients. And this risk is much greater for the young ones in the 0-19-year-olds. Now, what about the thyroid cancer in children and adolescents? Do we observe the same situation as in adults? What is overdiagnosis or true increase? In this slide, apologies that it's a bit overloaded with many panels in the same figure from 2021 from the International Agency of Research Against Cancer. It is shown that this is true, it happens. In some countries, it's much more like in South Korea that you see on the upper left slide, but there they have a program of systematical screening in the country, which is not advised. It shouldn't be done, but in South Korea they do it. That's why they have so much increase of incidence. Actually, they are the first in the world. Now, a few words about the thyroid cancer in children and adolescents in general, about the characteristics. Although it's rare, it's the most endocrine tumor in this age group. It represents 11% of the adolescents group, 1% of all the tumors at any age, and in the 15, 19 years old, and mostly in females, it's much more frequent, and 10 times more frequent in adolescents than in younger children. Again, papillary type is the predominant. Now, it's important now to spend a couple of minutes about risk factor causes, because by knowing them better, we can make better prevention, and we will see that there is a lot of work to be done on this field. The most established risk factors is ionizing radiation exposure. This is well known. It can be external by exposition to environmental sources, or internal by ingestion of radioactive elements. X-rays, CT scans is well known. That's why we conduct campaigns in Cyprus and elsewhere also to limit the examinations done for this, with these methods. Therapeutic radiotherapy for malignant situations like Hodgkin's, leukemias, brain tumors. Nowadays, we have limited enormously the leukemias radiotherapy, so we try to do the same thing in Hodgkin's and other diseases. However, radiotherapy is still administered. In former times, for benign conditions like thymic hyperplasia, tinea capitis, tonsils, also it was administered, but nowadays it's limited. The nuclear problems with atomic bombs, nuclear accidents such Chernobyl, Fukushima are well-known cases. And in addition, we have the ingestion of radioactive elements such as cesium, iodine, who have the tendency to be concentrated in milk. So the cumulative internal radiation exposure, it's an issue that occupies the researchers. Also, other risk factors who have been associated, the nitrates in drinking water. Countries with volcanic activity like Hawaii, Iceland, Sicily have had higher incidence rates. Chemotherapy, unfortunately, that we use to eradicate cancer, alkylating agents, they do can cause second cancers, and also thyroid. Immunosuppressive therapies, iodine deficiency or ovarigestion, female sex, as we have seen before, hormonal factors, estrogens, and endocrine disruptors, very important, like phthalates, BCPs, and others who are very abundant in our environment. Persons who suffer from autoimmune diseases such as Hashimoto, Graves. Obesity is very important as a risk factor. It is well known that obesity now is associated with more than 8 kinds of cancers, and all, including thyroid, and smoking, especially non-carnal smoking. The second big category of factors are the genetic alterations, are these rearrangements or point mutations or fusions. In papillary thyroid carcinoma, we have the red gene alterations, rearrangements that are much more frequent in children, and we will see that in children and adolescents. Actually, although the papillary thyroid cancer shares the same histologic figures like in adults, actually researchers believe that it's a different disease because exactly they have different rearrangements than in the adult setting, where the BRAF alterations are much more frequent. In follicular thyroid carcinoma, which is more rare, we have RAS genes point mutations. In the medullary thyroid carcinoma, we have red point mutations. Another important group that we always have to bear in mind in clinical practice is when we have cancer predisposition syndromes, such as familial adenomatous polyposis, Carney complex, P10 amartoma, MEN syndromes, Dicer, Lifraumeni. The individuals from these families need need good surveillance programs because they might have increased chances to develop cancers, including thyroid cancer. Another important thing that before I advance to further presentation of the problem is to remember always that there are significant differences between children, adolescents, and adults. The thyroid needles are much rarer in children, but much more frequently larger in size and frequently cancerous. Histology in the 0-19 years old is more frequently differentiated with more than 90% papillary, and the genomics alterations, as I mentioned before, are different between papillary in children and in adults. They are more aggressive tumors in this age group with much more frequently locoregional spread and metastasis to the lungs or sometimes to the bones and to the liver. Also, they present more frequently recurrences. I already spoke about the aggressiveness of the same histology. And always we have to remember the therapy's long-term effects, because in pediatric oncology, we try to cure more, but to cure better without long-term sequelae for the survivors. And of course, when we treat children, we know that any sequela will be for the whole lifetime, as lifespan is expected much longer. However, in spite of these differences, the prognosis in children is better, with cure rates close to 100%. Because of these differences, there are specific pediatric guidelines, such as the one by the American Thyroid Association, who have to be used in this setting. Now, is it like in adults, the overdiagnosis factor, or do we have a true thyroid increase? Well, I will start with what we did in Cyprus. We did a study in Cyprus over a 20-year period, 1998-2017, and we studied the incidence rates, temporal trends, survival, by using the Pediatric Oncology Registry Cyprus, because we created this registry and we are contented we have this since the 1990s. As you will see here on the lower part of the slide, the international characteristics of quality are very high. So we have a population-based registry with good characteristics. This is a paper that was published about the study of thyroid cancer. And the reason I showed this to thank our colleagues, international colleagues, in particular Friederike Erdmann from Mainz, Arne Bockert from Düsseldorf, Triantafyllia Brozu from Düsseldorf, and Linda Sharp and Richard McNally from Newcastle, UK. So we have an international team of experts who help us to understand very well what happens in Cyprus, and hopefully we can find conclusions that could be applicable to our population. Very quickly, the results of our study: 81 patients. In the red color, you see the most important findings that I'm going to refer to. 81 cases, 62% females, 65% in the 15-19 years old, mostly papillary type. And as you see, the metastatics is the regional, mostly metastatic cases, are 37%. We compare the second decade of the study, that means from 2008 to 2017, to the first decade, and I will stay only on the increase of the metastatic cases that you see in the red on the lower part of the slide, that shows that it's an almost 4 times increase. Some slides here that they show the annual percentage change for the whole group, 7.6% per year. For the females, for the whole group, 5.1% per year. For the males, interesting, because as in other countries, we see that also starts increasing with 8.4% in our country. And for the 15-19 years old, 7.6%. The key findings in Cyprus among the world's highest when we compare it with other countries, mostly in the 15-19-year-old, 7.5% increase per year, 10% of the cancer burden in this age group. Female is 3.5 times more affected, papillary type the most dominant, 4 times increase of the metastatic cases. And this is important because it advocates more in favor of a true increase of thyroid cancers that need therapy than our diagnosis of thyroid cancer that does not need therapy because it has a different biological behavior, has 100% survival, and importantly, previous cancer therapy did not contribute to the increasing rates in our country. For the cancer predisposition syndromes, we were not able to answer this question now because we are in process to make a new study for this, as we didn't have yet the data. As I mentioned before, we compare with other countries. Similar findings in many other countries, such as USA, South Korea, but South Korea, as I said before, the overdiagnosis factor is important as they have systematic screening. Italy, Chernobyl affected countries such as Belarus, Ukraine, and Russia have similar findings, but in others such as Denmark, Netherlands, and Poland, no such changes. What about the adults in Cyprus? Well, this was studied for the decade 1998-2008 by Kuder and others, and also they show rapid increases in incidence of thyroid cancer for all ages, and again, more common in females. We had some weaknesses, of course, in our study. Small population of Cyprus, small number. That's what we have. That's what we study, and we try to make the best out of it and compare in the best possible way with others. Unavailable information for the size and number of thyroid nodules, but this is not any information routinely collected by the registries. However, we have information about stage, which is important, and many other much bigger studies who go to conclusions. They don't give any information about size, number, or stage. In our case, we had information about stage, and this showed that we had 4 times almost increase of metastatic cases. Our strength is a novel study, new data. The quality indices were good of our PORC registry, high quality follow-up. We created an infrastructure with the help of our international colleagues that I mentioned before. We created an infrastructure for further population-based studies. We can study also now the molecular identity of all the cases, and we can establish a long-term follow-up. For the conclusions, I will stay only at the 4th point, the increased metastatic cases. And because, okay, now I end my presentation. So we found these things, I presented you the situation, and now what? After our conclusions, what do we do? Because we do something because we want to arrive to something. Now we have a plan, and our plan of action has 3 domains for our age group. I will explain them a bit more. The first domain of actions is limit useless screening, increase specialization, centralized management. Concerning screening, as I said before, major organizations advocate against it and the experts, so we don't have screening program and it's not necessary. However, we have a problem in Cyprus because we need to promote specialization for the management of children with thyroid nodules. Actually, everybody manages it in different ways, and this is wrong. It should be centralized in specialized centers, by ultrasound done only by experienced radiologists, fine needle aspiration to be done and interpreted by experts, and follow protocols such as the one from the American Thyroid Association. This is a big problem in Cyprus because we need to specialize, and I would say not only for children, but for adults also. Second domain of actions is to pursue our search for the risk factor causes, because as pediatric oncologists, we want to cure more and cure better, but we also want to understand the causes better, prevent more and prevent better. Therefore, at least in our small country, we will start because we have some advantage of being a small country, because perhaps we can control better the situation in our small island. We will pursue the descriptive epidemiology studies, incidence trends, geographical distribution, survival, to define hypotheses to be tested analytically, study the genetic makeup of the cases already registered, to see exactly in our population what happens with the cancer predisposition syndromes. And it's very interesting chapter, this one, because as Cyprus, it's an island, the gene recirculation, although there is not a hemomixia, consanguinity. However, because we are all living on an island, the gene recirculations, we are suspecting that the cancer predisposition syndromes might be interesting to explore. Also explore the relation of obesity and overweightness, who are really a huge problem in our country, in children and also in adults, to see their relation with thyroid cancer and also with other cancers. Environmental contaminants, very interesting, because there is a number of studies being done in Cyprus now for radon, for calcium 137, iodine 131, and nitrates, arsenic, endocrine disrupting chemicals, but they are disparate, let's say, studies, and we will try now to put all this together by a close cooperation between pediatric oncologists, epidemiologists, certainly, and other scientists, to see if we can find any solution. And again, I said, being an island, perhaps we can discover certain things because of this situation. Also, in the domain of better surveillance, we have to define the individuals at risk, the ones who have been subjected to ionizing radiation exposure, either that they are survivors of childhood cancer or receiver of radiotherapy of benign conditions, those suffering from thyroiditis, those recognized having cancer predisposition syndromes, those under immunosuppressive therapy and chemotherapy, and those with family history of thyroid cancer. These persons should be put under a strict surveillance program, either by the pediatrician, pediatric oncologist, or by the family physician. And also we will increase our campaigns to limit useless diagnostic radiation, which is a big problem in Cyprus with X-rays and CT scans, fight the obesity and overweightness, and increase our anti-smoking campaigns, explore better the iodine diet, and campaigns in cooperation with other authorities to reduce nitrates in drinking water, agricultural, fertilizers, and in general in the food chain. Conclusion, there are many challenges in the management of thyroid cancer in Cyprus and elsewhere. There are opportunities we need to ask, we have to act. We need to boost research, fundamental, epidemiological, clinical for this disease, better define the risk factor to find the etiology and act better for prevention. Specialization, very important to start with, and that would be a major domain of action in the next, let's say, years, to centralize their management according to the principles I already mentioned, and of course to fight for equal access for everybody, for get good standards of care, expertise, innovative therapies such as targeted agents such as tyrosine kinase inhibitors. This is our plan, and thank you very much.